Welcome to the Mom Needs a Moment podcast. We're your hosts, Chrissy
and Cindy,
co-founders of Her Health Collective.
We are two moms obsessed with revolutionizing the way moms take care of themselves. We are so glad you're here. Let's dive in. Dr. Rachel Goode is an assistant professor at UNC School of Social Work and an adjunct assistant professor in the Center for Eating Disorder Excellence, Department of Psychiatry, the University of North Carolina at Chapel Hill. She's also a licensed clinical social worker. She has her PhD, her Master's of Public Health, and her Master's of Social Work. Dr. Rachel's research interests include developing, implementing, and evaluating equitable and community-engaged interventions to treat obesity and eating disorders. In our discussion, Dr. Rachel explains what this means in more detail. I'd like to mention a trigger warning. We will be mentioning the topics of weight and eating disorders. If this is difficult for you, please listen to your needs. Hi, Dr. Rachel. Can we call you Dr. Rachel or should it be Dr. Goode?
Dr. Rachel is fine, or Rachel. That works too.
Okay. Hi, Rachel. But I think you've earned the doctor part. That's why. That's why I thought I'd say that.
Okay.
So we are really thrilled to have you here today. You are doing some amazing work, and we'd like to have you introduce yourself to our listeners. So in 2 minutes, could you please wrap up with a little bow who you are and some special things about you?
Sure. So I wear multiple hats. So as pertinent to your listeners, I'm a mom of two boys, a 9-year-old and a 3-year-old. And then in my out of the house job, I work as a research professor at UNC, mostly doing research to develop treatments for those at the intersection of eating disorders and obesity. So thinking specifically about that group of people who are just kind of navigating their relationship with food and trying to figure out, which it can be kind of crazy to do that in this culture. And so trying to find a way forward to a place of wholeness, to a place of freedom, peace. I feel like we know a lot about how to help people lose weight and also how to help people get eating disorders, unfortunately. But we don't know a lot about how to help people live at peace in their bodies and to find a way forward that allows them to, again, just experience a sense of wholeness and freedom in their relationship with food. And so I feel like out of my own personal life, I have seen my own story become something that I think can help encourage others. And through science, through my clinical practice, I'm also a clinical social worker. So putting them both together, a coach, a weight and wellness coach. I do a lot of things. So just wanting to put it all together to be able to help people as best I can.
Oh my gosh. So much goodness in that 2 minutes. There's so much to unpack there. Yes. How much are they spending in the health and wellness industry now? What is it? Like billions?
Billions.
Yes.
Billions for the promise. I think that shard of hope, like this is going to be the thing that's going to fix my problem with food. And of course, we all know it's never the thing.
Oh, and it's so important. So
Yeah.
important to have people like you and other therapists that are helping to teach the ability to have that good relationship with food, that food is meant to be something wonderful. And we've turned it into all things good, bad, in between. There's political, it's everything.
It's a lot. It's a lot.
Yes. Oh, I'm excited to go in deeper in some of those topics that you had just talked about.
And goodness, you do wear so many hats. As you were going through the list, I just kept saying, wow, there's another hat. And a mom of a 3 and a 9-year-old, you're at two different ends of the spectrum. I mean, that's two different hats right there, a 3-year-old and a 9-year-old. Those are two different hats.
Yes.
Oh my goodness. Okay. This is probably my favorite part of the podcast is when we get to ask our quote unquote fun, quirky question. So I want you to pick your favorite number, 1 to 10, and I'm going to choose from our 2000 Questions About Me book. So 1 to 10, go ahead.
4.
Ooh, okay. I feel like 4 is not a number we hear very often.
Yeah.
Really?
Is that your favorite number?
My goodness.
Is it your favorite number?
I don't want to weird the folks out, but I have always loved the number 4. Like, there's just something about it that just felt like, again, if I could put, personality characteristics to numbers. 4 just felt like a warm, friendly number. And as a child, I always liked even numbers. And then 4, there was just something about 4. So when you said that, Chrissy, I was like, I know what number.
I know. I would, without question, pick number 3. Like that's always my go-to number. So this is kind of just a random aside. Do you like follow Enneagrams at all, or do you know anything about the Enneagram?
But not deeply. Yeah.
Okay.
Not deeply.
One of our expert panelists this year is an Enneagram expert, and I would be interested to know if you were a number 4. This is totally no scientific basis, but 3 has always been my favorite number, and I am technically a 3. So I'm just totally like an anecdotal.
To look and come back. Yeah.
Okay. Let me know. Okay. But anyway, question 4. What was the most memorable class you've ever taken in school or college?
Oh, wow. And you had a lot of school.
That's a good one. Okay. I took a conflict resolution class, and it was a lot. So we were literally being trained to like mediate serious conflicts. So it was, I think, one of the best experiences I've had. It was harder than I thought it was going to be, to really hear what the other person's saying, capture the concern, yet move the conversation forward. It was great practice. I think it led me, it was like a foundation for my future work as a clinician, a social worker, and just to all around just helping navigate interpersonal dynamics. So
I'm sure that's a skill you use all the time. I mean, daily.
I don't even realize how much I use it.
I can also see that class was probably very emotionally draining. Like when you left class that day, it was just like, ooh.
It was a lot.
Was it your undergrad? It
was undergrad. It was my undergrad. That's the thing. Like, I didn't really have a lot of skills, but I was like, I'm a good listener. But there's a lot more that's needed to resolve conflict than being a good listener. So
I think that should actually be a required That should be a required class.
Yeah, it was great.
There would be so much benefit in the world.
Yeah, it was good experience.
Were you tired afterwards? Like you said, were you drained?
I was, but I felt like I remember feeling like, I'm not getting this. Like I enjoyed the class, but I really wasn't like a star in the class because I got stuck a lot because I'm like, okay, they're mad. How do we get them back together? And trying to help people come back together was more complex, I think, than I anticipated it to be.
What were your tests like? Were they like paper, multiple choice, or did you actually have to do it?
We were doing it.
Oh, you were in it.
Yes. So we'd have like actors come in and they'd have their conflicts and we'd have to kind of help navigate. So again, I was 20, 21, didn't know what I was doing.
Wow. And conflict is so uncomfortable, at least for me. I feel I've had to talk to my therapist about it a lot. I'm like, what do I do with this awful feeling inside?
Yeah.
So
it's horrible. It's so hard for us. So I don't know what I was thinking, but it was great experience. They didn't ask me to come back, needless to say, but I learned a lot.
That's amazing. I love it. That's great.
Yeah.
So as you've already mentioned, Dr. Rachel, you're an assistant professor, right? You talked about research, but you're an assistant professor at the School of Social Work at the University of North Carolina at Chapel Hill. You are also the lab director and principal investigator for Living Free Lab. That's FREE. And that stands for Research Focused on Reducing Excessive Eating Free. Your research interests include developing, implementing, and evaluating interventions to address the racial, ethnic, and socioeconomic disparities in obesity and eating disorders. So I just said a lot of words right there. Yes. Will you please put this into layman's terms and just explain how you've developed this passion in this particular area?
Sure, Cindy. So when I think about what I do, I just want to, so again, we have a treatment that we've used, when someone says, oh, I want to lose weight, or the first thing I think people know to do, right? You're going to count your calories, you're going to exercise, like that's our common treatment. But we also know that treatment doesn't work. Like it doesn't work long term. And then it has really, I think, fueled a lot of other people kind of just taking things in their own hands and people risky diets that can also lead to eating disorders. And so I find myself really wanting to develop treatments for realizing that there are many reasons why people want to lose weight. And I think we want a society where people don't feel like they want to change their bodies. We want that to be the case. But again, I've seen in my research, heard from our participants, people want for various reasons. And how do we support people on a journey that we may or may not be wanting them to take, right? We want, I think, people to feel whole, right? We want them to feel good in themselves, but we all make choices, I think. And I want to be that friend, right? To be the friend, be like, okay, if you have to go down this road, if you want to go down this road, how do we do this in a way that leaves you coming out at the end, feeling healthy, being able to have an improved relationship with food, to be able to be at peace with your body? Like, is that even possible? And I think for so many clinicians, I think the answer has been, I don't know if it's possible, right? And I've seen a lot of harm that obesity treatments can do. But I love, as a researcher, we design things that don't exist yet. And we recognize we can dream a little bit, right? I think researchers have the ability to dream a little bit, to still put your feet forward and move in a direction that people are like, I don't know. Because I don't know if we can afford to not do anything because I don't think we can afford that. And so I love that I get the ability to continue to still see what works and see what we can do to help people.
Right. And so a good chunk of your research has been addressing the racial, ethnic, and socioeconomic disparities in this area, right? Can you talk a little about that and
Sure.
What pulled you to want to delineate where your research was going?
Yeah. So there's a couple things. I think the first thing that got me interested in this was that I just got tired of hearing the same disparity. Like, okay, in treatments for weight loss, Black women do the work. Like they don't lose as much weight and it doesn't seem to benefit them as much. So when I was a student, that bothered me. I was like, that's getting on my nerves. I'm tired of hearing that stat. What is it?
Right.
Like what's going on? And then as I started looking more into it, I started recognizing that there are a lot of people who don't get treatment for eating disorders. And, we have so many stereotypes about who has an eating disorder. What does it look like to have an eating disorder? That really limits us, I think, as a culture to be able to treat eating disorders effectively, because people go to their doctors and if you don't look, right, you don't fit the stereotype, which I think is, thin, affluent, cisgender, female, white, you don't fit that stereotype. I think the doctor's kind of like, I don't, they're not looking. And so I think people just honestly feel like, I don't know what to do about eating disorder. And so those people, are being then sent to weight management treatment. And that it could be the worst thing for them, especially if people aren't really equipped culturally, I think, to understand what eating disorders look like. Again, we have a treatment that, because it's kind of, anybody can really, give you advice on losing weight. And a lot of that advice can really be harmful. And so it's kind of the wild, wild west out there, and recognizing that people who look like me aren't really getting the help they need and aren't really being considered at the forefront of treatments. We might get, like the seconds, but what would it be like to think of what would we need to do well in a treatment? And what are the eating issues, more than maybe the outcomes of the weight loss, like what's going on with people's relationship with food, how they're interacting with food. Like, can we just take it down a step and kind of unpack what's happening that's influencing the choices people make about eating? So it just, when I think about poverty as well, like we don't talk enough about how those dynamics show up in our ability to make health choices in this country. We talk a lot about in social work and in public health, the social determinants of health, right? Recognizing that my ability to take steps to improve my health have less to do with my individual choices and more to do with some of the systemic factors that I have no control over. What's in my neighborhood? How safe is my neighborhood? Air quality, thinking about the support that I'm able to have, my level of education. These are things that we don't always think about racism, just neighborhood trauma, historical trauma. These are things that people are carrying with them that influence in their ability to pursue health. And so far, we've really focused a lot on the individual choices, which are a part of it, but may not be the strongest contributor to people's ability to make the changes that they want to seek.
Yeah.
To our Patreon supporters, thank you. We appreciate you so much. Our goal has always been for moms to know they're not alone in the tough and challenging phases of motherhood. We know Mama Needs a Moment provides this to our listeners.
We are thrilled with the growth of the podcast over the past 2 years. Last year, Spotify shared that Mama Needs a Moment was in the top 30% most followed podcasts, was heard in 9 countries, and had more content than 97% of other creators in the family category.
We have recently launched a Patreon account for Mama Needs a Moment. This is a great way for you to provide additional support to Her Health Collective.
We've set up 3 options for Patreon supporters, each with its very own perks, such as special events, discounts, and bonus content from each and every podcast guest that is available only to our Patreon supporters.
Will you become a Patreon supporter? It would mean the world to us. I would actually love to ask you more about that because this next question goes into a lot of what you just talked about. Yeah. According to the National Eating Disorders Association, eating disorders affect people from all demographics of all ethnicities at similar rates. People of color, especially African Americans, are significantly less likely to receive help for their eating issues. Right. Just last month, I believe, unless my timing is off here, you were awarded the SSWR Deborah K. Paget Early Achievement Award. Congratulations.
Thank you. Thank you.
It was in recognition of your research on the intersection between eating disorders and obesity. In your attempts at finding effective interventions for marginalized communities. Earlier, you mentioned that as a researcher, you get to dream. And I'd love to know, what are you dreaming up in this space? And can you walk us through, you touched on your research a little bit, how it was these individual choices, but I'd love to know a little bit more specifically what your research looked like there.
Sure. So I think I did an intervention study. And I looked at this program. It was called Appetite Awareness Training. And so you all can look it up. It's out there publicly available. And what the program does is help people relearn their biological signals of hunger and fullness. And ideally, it was created for use in individuals who are managing binge eating, bulimia nervosa, and to kind of help. And often in eating disorder treatment, the first stop is to help people start to eat regularly throughout the day because something often has happened. So people's eating episodes are not regular. So that's one of the first stops. So in the treatment, we work to kind of help people, eat regularly. And I can't tell you how many people on a normal, for various reasons, right? We know that it's complex, but people are often not eating throughout the day. Often my participants are skipping meals. Maybe they'll save their calories for one big meal, and the body, what we've seen in the research, it just doesn't operate best like that. And it can set people up to have binge eating episodes. So again, when you think about this program is designed to help people reduce that. So the first stop is helping people listen again to their hunger signals. Again, our culture, it's kind of maybe I'm hungry, maybe I'm not, right? There are lots of reasons why we decide to initiate an eating episode. But really helping people kind of tune in to your body again, to connect. I definitely think there's a mindfulness element to this program. And so one of my first stops was see, this program, so it wasn't really designed to be used. It was tested in a sample of white women, right, college-aged women. Could this maybe work on urban Black women of various income levels? Could this work? So that was my first study, just to kind of test it out. So it was 8 weeks. And we took 2 groups of women. One group got the intervention first, and the next group waited 8 weeks. And we wanted to compare what happened. And so what we saw was, if we compared the group who got it first and the group who waited, we saw that the group who got it first, their binge eating reduced. They were able to improve their ability to cope without using food, right? With their emotions. We noticed that their depression, their feelings of depression they lessened. And so that got me excited. I was like, okay. And people, I think, generally felt more equipped to manage their relationship with food. Like, I think confidence is something we don't think a lot about. Like, how confident are you? And I think our culture with, you don't feel very confident when you're approaching these, eating programs. You're just like, I can't do it. But when women came out of this program, they felt better about themselves. They felt like, hey, I can do this. So that caused us to think, okay, but we didn't see any changes with weight. There was nothing different between the groups. And so knowing that a lot of women are still thinking about their weight, right? Often women who binge eat, they're either gaining weight rapidly and they're not really able to control it, or for various reasons, they still want to lose weight. So our next study was, let's look what happens when we add some nutrition training. Again, not calorie counting, but just helping you be equipped. I feel like giving you your armor to be in our culture and just kind of survive and, be able to kind of be on the top versus feeling like you're pinned to the mat, which I can think it can very much feel like that, but to arm people with some things to help them feel better. So we gave them 8 weeks of AAT, and then we added some nutrition, like some stuff from the diabetes prevention program, just kind of see what would happen. So we noticed when we did that, participants, they were able to maintain their weight a little bit more and they felt better, so it was everything. We lost the binge eating and then they maintained, which again, can be such a big deal in a culture where people are just up and down, but can we help you be stable, right? Wholeness, freedom, like to have a strategy for if I'm just living my life and I just want to be, how can I learn how to eat, And so, and I think that's really what we saw, like, okay, people are learning how to eat. Oh my goodness, like this is so cool. And so then we said, okay, well, we just did another study where we did like 8 weeks of AAT, 8 weeks of the nutrition program. But then we're like, we're going to mix it up instead of just doing sequential. Let's do it at the same time. And so what we noticed in that study, and that one was with, I'd say predominantly Black and white participants, like 50-50. And so what we noticed was participants, again, they still did well. They even lost, some people even started losing weight, but all of them had reduced their binge eating, their emotional eating, and they were feeling good, right? They were coming out feeling good and they maintained it. We did a 2-month follow-up and that they were able to maintain it. So it's given us hope, right? We know we need to test it in our larger sample. We know there's more needed, but I feel like we're really beginning to put some of the pieces together to understand, how do we approach this in a way where people are positioned to be healthy at the end of it? And it's more than just being able to lose weight, right? Because we know people lose it and then they gain it right back. So it's more than that. And honestly, we only talk about losing weight as a treatment for obesity, but we minimize the effects of just maintaining your weight. Like that is a huge treatment and it really can prevent cardiometabolic risk factors. So we're just kind of learning, and I just love it because I'm like, okay, we see something else. We use some digital health aspects, to see what we can do, especially us in COVID, everybody was at their house. So how can we continue to still move forward and get to people? So yeah, so we're having a good time. It's been really fun and meaningful work.
I love it. What I picked up on as I was listening to you is that so many diet protocols are very behavioral oriented. You fast for these amount of hours or you eat this specific food. It's very behavioral in manner or in what it's asking for.
Yeah.
What I see in what your dream and what you've outlined in your research is this mental emotional piece that focuses on intuition and building confidence in a person's food choices, and then tying in that knowledge piece, which we know is so important, because if we don't have the knowledge about certain food and how that impacts the body, then the decisions won't be there to make. But I love the simultaneous piece between that knowledge and that mental emotional piece. And what we know about behavior change in people is that it does require, for that motivation change, that it requires that emotional piece, that mental piece. So it makes sense to me, basically. Yeah. You mentioned this a couple of times throughout, but I would love to dive into this a little bit further. we know, obviously, we hear about it all the time, that there's this disparity in the medical community. So we talk about it a lot on Mama Needs a Moment when it comes to Black maternal mental health. But you do a lot of research specifically in the area of recognizing eating disorders in certain communities, specifically for Black women. Why is it the same? Is it the same across all the industries? Or do you notice that there's something else when it comes to eating disorders of why this disparity exists?
So it's a couple of reasons. One, I think one thing is great if you can catch an eating disorder before it becomes officially an eating disorder, like disorder eating, when you're like, before you can get like a diagnosis, right? And so often though, because people don't recognize the symptoms, don't recognize that, hey, this is something that it matters, right? Like these are things that people are, I think, realizing, oh, maybe it's just me, like this isn't a big deal, I just need to deal with it. And so there's just not a lot of knowledge about eating disorders, I think, within the community, because again, stereotypically, it's like, this is not our issue, this is someone else's issue. And so I think that's one of the reasons that affect the disparity. Another, I think often we've thought it's that desire to be thin that really fuels all eating disorders. But what we're learning is that it's bigger than that. It's recognizing the influence. Like we're learning more about food insecurity. And when people don't have access to meals, again, it's the reason it's different, but people are still restricting their eating. And so seeing that some of my participants were dealing with food insecurity, poverty, also trauma, sexual abuse, racism, acculturation, just the stress of trying to be in a culture where you're not the majority, and some of the stressors that deal with that, people use it as a coping tool. And so, but I think for so long, our focus has been very narrow, thinking it's like that thinness, trying to be in it, that does affect that pursuit of weight loss. That is definitely an impact, but there's other things. I just think our clinicians haven't really been armed with all the tools that they've needed to really begin to see it, to recognize it. Our primary care physicians, I think they're our first line of defense often, because people see them probably more than any doctor. But they've admitted, I don't know what eating disorders look like, but they do know a lot about obesity or a lot about BMI. And so might be referring people for weight loss treatment when they need eating disorder treatment. And it's causing, and people are hiding in plain sight with their eating disorders because no one really knows what they're looking for. And we do this thing as a culture. People lose weight. You're like, oh, that's so wonderful. Not realizing, oh my goodness, you don't know what was going on behind that. And for so long, it's been about that bottom line, oh, did you lose weight? Great. Recognizing that we are hurting people and missing things and not seeing each other really well. So there's just a lot for us to learn.
Yeah. I have a loved one who went to the doctor, and the doctor's intentions were good, certainly, but they shamed this person essentially for being obese. And that person no longer seeks out care, no longer wants to go to the doctor because they know that they will be shamed in that scenario. And I think in so many situations with our medical system, intentions can be good, but again, how it is being delivered and the focus, what our medical system is focusing on is misplaced. It's kind of missing the mark there.
Oh my goodness. I can't tell you how many people have those stories where they have been, scarred, right? I think, again, we all can look back and think of a weight story, especially as women in this culture. You remember those moments. They stick with you, especially if it was family members, meaning well, made comments, these things mark us for life. Like they mark us for life. And it's sad. It saddens me to hear of so many people who that weight stigma is such a real, and again, we're talking about it, but I hope we'll actually be able to, stand up against it because it is seriously harmful and preventable. Like we can do better, folks. We can do better.
We continue our talk with Dr. Rachel next week when we go into more depth about her experiences of eating disorders, finding food freedom, and what she envisions making better for others. We will also go into more depth on what she has found to be medical professionals' biases and how it's identified in members of marginalized communities and changes that need to be made in the medical community to approach and treat these patients. Here are our 3 takeaways from today's episode. Number 1, in her research, Dr. Rachel started recognizing that there are a lot of people who don't get treatment for eating disorders. This is due to our culture's stereotypes about who has an eating disorder, what it looks like to have an eating disorder, and that limits us. Dr. Rachel feels that in order to understand what eating disorders look like, we need to have a treatment that takes so much more into consideration than the outcomes of weight loss. She mentioned getting more clarity on what's going on with people's relationship with food, how they're interacting with food, what's happening that's influencing the choices people are making about eating. She feels it has less to do with individual choices and more to do with some of the systemic factors that people have no control over. For example, what's in their neighborhoods, safety, air quality, support, levels of education, racism, neighborhood trauma, historical trauma. These are things overlooked and that people are carrying with them that influence their ability to pursue health. Number 2, Dr. Rachel explained some of the results of her research. One of the first was an intervention study that looked at a program called Appetite Awareness Training, or AAT, which helps people relearn their biological signals of hunger and fullness. To help in eating disorder recovery, the first step is often to help people to start eating regularly throughout the day, guiding people to tune into their bodies again, because often this has been disrupted. She tested this program on urban Black women of various income levels, and what they found was binge eating was reduced, and they had better ability to cope with their emotions without using food. Their feelings of depression were lessened, and they had increased confidence about their ability to make decisions around food. The next study applied the 8 weeks of AAT, followed by nutrition training from programs like the Diabetes Prevention Program. It's knowledge, not calorie counting. The results? Participants were able to maintain their weight and felt better. What they found is that people were learning how to eat. Another study consisted of 8 weeks of AAT, 8 weeks of the nutrition program, both at the same time. They found that all of the participants had reduced their binge eating, emotional eating, were feeling good, and after a 2-month follow-up, they maintained it. Dr. Rachel and her team are putting some of the pieces together to better understand, quote, how to approach this in a way where people are positioned to be healthy at the end of it, end quote. Number 3, when we asked Dr. Rachel about recognizing eating disorders in certain communities and what's the same and where there's disparities, Dr. Rachel said that across all communities, catching an eating disorder early, before it gets to the stage where a diagnosis can be received, is so important. Another similarity is disputing the thought that an eating disorder develops only from a desire to be thin. What Dr. Rachel and her team have learned is that it's much bigger than that. It's recognizing the influences. This is where there's disparities. Things such as food insecurity and when people will have access to meals, poverty, trauma, sexual abuse, racism, acculturation, just the stress of trying to be in a culture where you're not the majority, and some of the stressors that deal with that. People use food as a coping tool. There's many other things affecting the development of eating disorders, and Dr. Rachel feels our clinicians haven't really been armed with all the tools they need to really begin to see and recognize it. In Dr. Rachel's words, quote, recognizing that we are hurting people and missing things and not seeing each other really well. There's just a lot for us to learn, end quote.
High five, friend. We've enjoyed hanging out with you. Follow us so you're the first to know when we drop a new episode.
If you've enjoyed your time with us, let us know by leaving a review. We always love hearing from you. Until next time, stay true to you.